This is Dying Your Way.
Welcome everyone to the Dying Your Way podcast. I'm Claire O'Berry. Today we have a somewhat controversial topic that we're covering. It's about voluntary stopping eating and drinking, better known as VSED. And at Dying Your Way, we advocate for a natural death that is neither hastened nor prolonged. Yet I've worked with clients and families who have used medical aid in dying, or in Australia, it's called voluntary assisted dying. In many countries and states, this is not a legal option for people. So VSED is an option that could be considered. Dr. Judith Schwarz is so knowledgeable in this particular topic and is in New York City. She's with End of Life Choices in New York. And at this recording, it is not a legal option to do medical aid in dying, though there is a bill on Kathy Hochul's desk, and perhaps she will sign it into law by the time this podcast is published. So if what you're hearing is disturbing for you in any way, stop listening, but also be aware of what your local crisis hotlines are and use them if it does bring up issues for you. This is just another way that we can be curious and expand our knowledge of death literacy, which is the purpose of Dying Your Way and this podcast. So here is my interview with Dr. Judith Schwarz.
Welcome, everyone. Welcome to the Dying Your Way podcast. We have an interesting topic today. Some might even say controversial. It's called VSED, Voluntary Stopping Eating and Drinking. Now, we've done a program before about medical aid in dying, or in Australia, that's called Voluntary Assisted Dying. This is something a little bit different, and I've got an expert in the subject that I am really excited for you to meet, because she has really done so much in the state of New York. But I think now we're looking at this as certainly the United States, where it's legal. I've checked in Australia, it's legal in Australia, it's legal in New Zealand. It's just a way to hasten death if without going through the whole medical aid in dying. Judith, she's got a very impressive resume, so I'm just gonna read her bio before I introduce her to you. For 20 years, Judith Schwarz, she's an RN and she has a PhD, and she's counseled suffering people that have life-threatening illnesses about end-of-life options and choices. And the topic of her doctoral dissertation was actually on the end-of-life choices that we're going to talk about. She's a clinical director of End-of-Life Choices of New York, which is dedicated to improve and expand choices at the end of life. And in that capacity, she's counseled hundreds of people who have serious illness to end-of-life legal options. And voluntary stopping eating and drinking is just one of them. In addition, Judith, with colleagues that were in medicine and law and philosophy, developed an advanced care directive that is specific to stopping eating and drinking. So persons that are in the early stages of dementia are able to have the capacity to make decisions. And we'll be talking a little bit about that. She's a researcher, she's a lecturer, and an author. We'll be hearing about her book on the topic of VSED. And it's a peaceful way to die. And we're going to talk about that. And I'm just really excited for you to meet Judith. She's the expert that I found in this field, and I really wanted to talk about this topic. So with further ado, meet Judith Schwarz. Hi, Judith.
Hi there. Very nice to be with you, Claire.
Thank you. Thank you for agreeing to do this, because it's getting a little late on your end. And so I appreciate your time. I guess the first thing is just what prompted you in your life that you felt drawn to end of life choices and working in this field?
As often happens for people that do this kind of work, it was a personal experience. I had a dear friend who was something of a running partner, although she was a much better runner than I was. But she also had ovarian cancer, and she was the only one in her family who had insurance. And so she was supporting her husband and her 3 college-age kids. So she would work her chemo and her radiation around her school holidays, because she was a teacher. She taught dance. And as we would run along together, I said, listen, of course, I will be there for you in any way you need me to be there. I have no idea what that meant. Now, you understand, it's 20 years ago, actually a bit more than that. In any case, the time came when she finally said, I can't do this any longer. I'm in pain, and I really need you to help me. And in those days, I thought it was simple, right? If you get someone out of pain, they won't want to die. But that's not the case at all.
Yeah.
It's not about pain. It's about the existential distress and dread of living in a limited way, in ways that prevent you from doing the things that make life worth living to you. And I learned from her just how bloody hard it is to control your own dying. I didn't know what to tell her. I really didn't. She stopped eating and drinking for about 10 days.
On purpose, or just?
Oh yeah, thinking that would work. I had no idea, but I thought maybe it would. You have to understand, she was a marathoner. She had the best bloody cardiovascular system. She was tuned up. So she didn't die. She got tired, but she sure didn't die. And so in the final analysis, working with her family, and she didn't really have a lot of pain, but she did have some narcotics in the fridge. I said, listen, she had an IV at that point. She was in hospice, and they put an IV back in because she couldn't drink anything. And I said, I'll help you with the technical stuff, how you work the machine and how you could take the fluid out of the IV and how you can put the narcotics in, but I can't do that. And I have to leave because I had, high school aged kids, and I was a single parent, and I was a nurse, and I couldn't lose my license, right? And I might add, there was absolutely no direction out there. Nobody, there was some very primitive early groups, but nobody was telling you how to do whatever. And so her husband called me the next morning and said that she died peacefully. But I wasn't there. So I don't know whether she died peacefully. And so I was completing my master's at the time. And my next thought was, oh my God, what do other nurses do when they get asked by a decisionally capable patient for assistance in dying, whatever that means. Right. And so that became my PhD dissertation work. And when you
what was the title of your dissertation?
It was a phenomenological study, God help me all. The experience of being asked by a decisionally capable patient for assistance in dying.
Okay, good. Yeah.
And so I was very steeped in the literature. I knew a lot of people by then. And when I finally, finished my dissertation and defended it, published it, I thought, well, gee, I'll do more of this. It's so much fun. Fortunately, I came to my senses and realized that if you're going to teach, you're also going to have to, go to committee meetings and probably be nice to a lot of people. I'm not sure I was good at that time. So in any case, this organization in the very early days was called Compassion and Choices of New York. We were part of a larger organization. And in those days, Compassion and Choices of New York and Compassion and Choices both had two goals: to pass legislation to legalize medical aid in dying, and also to provide patient support. So in those days, we clinical coordinators around the country would have weekly meetings. We discuss patients. I was the only nurse, actually. I was the only one with any kind of clinical. I was an old nurse, so I had some skills that I could share.
Yeah.
But over the years, that became harder to sustain. It was hard to find people, and we had to work with volunteers, and it became pretty complicated. And meanwhile, slowly but steadily, laws were being passed in United States that legalized medical aid in dying. And started, as you probably know, in Oregon on the West Coast. Everything good happened on the West Coast, and eventually it comes east. And the model that Oregon passed then is the model that continues to be used by all states, which means you have two physicians that agree that a patient is both decisionally capable and in the terminal stage of their disease. They have to make two verbal requests with a 15-day waiting period and a written request, and they have to be able to self-administer the medication. So that has, and they have to be told about hospice and palliative care and other alternatives. And everybody that uses the medical aid in dying in the 10 states now that permit it are in hospice. You know, they want to have good symptom management.
Yeah. Oh, yeah. So is it legal in medical aid in dying? Is it legal in New York?
Oh, hell no.
No. Oh
No.
my God. That is so surprising.
Well, let me tell you about what goes on in Albany. You know, there's the upstate and then there's the downstate. I live in downstate, and we all speak the same language very quickly and don't suffer fools gladly.
You're Manhattan. There you go.
That's right. But upstate, they have a little bit different approach to it. It's very conservative legislators who are very significantly counseled by Catholic bishops in upstate New York. And as you, I'm sure, know, Catholic bishops or the Catholic Church is very opposed to anybody taking steps to hasten their own death. They don't even approve of VSED, by the way. So no, so we're surrounded by states that have medical aid in dying. New Jersey has it, Maine, Vermont, but not us. And it's embarrassing and it's horrible. And, for 7 years we've been trying, literally. But, then you get a whole bunch of new legislators and you have to start all over again. It's never even come out of committee, Claire. It's never been.
I'm shocked. I'm really shocked. I mean, normally New York is so progressive.
Welcome to my world. Yes. Yeah. So that's why VSED is the only game in town, because there is no alternative. I mean, people think, well, they'll just move to New Jersey. And I say, well, actually, you have to establish residency for 6 months. And then you have to find 2 physicians who will help you. And they don't want to help people from out of state. Mm-hmm. And one can understand.
Yeah.
So it's hard.
No, it just recently, July last year is when it became legal in Western Australia. So Victoria and Western Australia are the only places in Australia where you can do it right now.
And it takes a while, doesn't it? It takes a while before people know about it, figure out how to work the system and find physicians. I mean, it's a difficult path to follow.
Mm-hmm. Yeah, in California, I don't know about Oregon, in California, they've even reduced the 15 days. I think it's a few days, but at any rate, we're talking about VSED because you and I know what it is, but for the listeners, let's just talk about what exactly voluntary stopping eating and drinking entails.
Okay. It is a decision to hasten death that's made by a decisionally capable individual whose suffering has become intolerable or whose quality of life is simply unacceptable, who has no good alternatives, because believe me, this is nobody's first choice. And if you have, a nice implanted defibrillator that you could turn off, that would be great. Most people don't. So decisionally capable, very determined, and very well-informed adult who has decided that their current existence is unacceptable, and they want to take steps to control the circumstances and timing of their death by stopping all oral intake. Now, I will tell you the 4 things that must be there in place in order to be successful. So the first one, obviously, is the very well-informed, determined, decisionally capable individual with no good alternatives. That's number 1. The second thing they must have is good caregiving support, because you end up in bed, right? You can't get out of bed. After you stop eating for like 10 days, you're going to be too weak to do anything. We certainly don't want you getting up, falling down, breaking a hip. That's not good. So you stay in bed. You need 24/7 caregiving help. And you need psychosocial support. You need somebody who will agree, family members, close friends, who will journey along with you, who understand why you've made this choice, and who will support you along the way when things get tough, because they do get tough, particularly during the process of stopping eating and drinking. As death nears and organ failure begins to occur, you lose decisional capacity. You become confused. You forget that there was a plan to hasten your death, and you're thirsty, and by God, you want something to drink. So there needs to have been a very specific conversation upstream. While the patient is still decisionally capable, before they've started along this path, what do you want us to do? If you say, you forget that you're trying to hasten your death and you're thirsty and you tell us you want something to drink, many patients will say, just ignore me. Just don't pay any attention to me. Just don't do anything, which I'll tell you is very, very hard for family members to do. Extremely hard. Nobody wants to be the food and fluid cop, right? So, so what I recommend is that people consider limited comfort feeding only. So that's providing the least amount of fluid to provide comfort, but no more, and still attempting to honor the desire to hasten death. We don't worry about the food because you die of dehydration. It's not starvation, it's dehydration. And it takes, for somebody who is terminally ill or who has a serious underlying disease, it takes 10 days to 2 weeks. And somewhere in that second week, capacity will begin to get very wonky. So we're talking 2 things, right? We have a decisionally capable, well-informed, and very determined patient. We have psychosocial support from family and friends and caregiving help. The third thing that's absolutely crucial is palliative medical oversight, either palliative care or home hospice, because you need to have access and your family needs to know how to provide small amounts of liquid morphine under the tongue, small amounts of anti-anxiety medication between the gum and the cheek. The goal here is a sleepy kind of state from which you can be roused. We're not trying to snow you so that you're unconscious. We're sure that you don't suffer. This is not supposed to be torture. This is supposed to be as comfortable and peaceful as possible. The other thing that happens as you begin to get close to death and you begin to go into organ failure is people become agitated and delirious. There's a very specific medication that can be given that makes that go away. Hospice and palliative care are all over that. So families need to know that that'll probably
He says,
happen.
banging the table.
Well, I mean,
No.
doesn't everybody do that?
No, but I mean, but whether you're doing VSED or not, I mean, those palliative meds and that terminal agitation, it happens frequently.
Yeah,
So I don't know that
upsetting.
it's necessarily just from that you're doing the VSED procedure.
No, it's organ failure. It's
Yeah.
It's very, very frequently occurs. It's the last 2 or 3 days death is near. But again, nobody wants to experience that. The family doesn't want you to suffer. You don't want this to happen. Haldols, drug of choice, no problem. So, and then the fourth thing that's necessary is patience with the process. It takes time. Each death will unfold as it was meant to. There are some people who find going without fluids extremely challenging. And there's lots of easy sort of basic oral care that can be done.
The glycerin.
minimizes the symptoms of a dry mouth. And no, rinsing and spitting is the best, but you have to still be able to cooperate with that. And if you start drinking what you're swishing, then you know we got a problem here. But the swabby things and lip gloss and a washcloth that's been wrung out, put in the freezer so that you can have that in your mouth, anything that keeps you, a fine mist sprayed at the back of the throat, anything that keeps your mucous membranes feeling moist is what you want.
Mm-hmm, mm-hmm. Great tip.
So, as I say, it's a process and it unfolds over time. And some people feel that they need a little bit more water than others do. It's their choice. So they understand that they may prolong the process if they're taking little sips of water. And the goal, if you're giving a sip of water, you should also be giving more morphine because that patient is too awake. You want them to be in a sleepy state, not zeroing in on, geez, I really wish I could have a Coke with ice and a big fat straw, you know? So it takes thoughtful, clinical journeying with, but it's not rocket science. It's not complicated.
So what you're saying is very clear. And what you just said, knowing your own personal preferences, I think if people just anticipated their end of life, you know, you could go, well, you know, I might want that last drink of champagne after I come off dialysis. And I mean, I've been at the bedside with people where I'm giving them their best red, you know, that they want a straw. So, but the VSED part of it, and a lot of things earlier before any of this came into being, you know, there would be agreements with, like, I had an agreement with hospice. My mother died of Alzheimer's and she was in long-term care. And I didn't know at that time what a terminal condition would look like, but I made it really clear with the hospice team without any kind of formal paperwork that I wanted her to die at home. And when she got to that point, I wanted her to come home. Well, what brought her to that point? She couldn't swallow anymore. Mm-hmm. You know, so I got her home in just a few hours, and 3 days later, after not being able to swallow, you know, there were probably other parts of her brain that started the organ failure, but yeah, it wasn't long with my mother, but basically she was not eating and drinking for 3 days. But even if people are,
for that, it wasn't from 3 days, Claire. She must have been on a very limited intake before that, because 3 days is not enough.
No, I'm just saying it wasn't from, I don't think it was from VSED. I think it was probably another part of the Alzheimer's shutting off something that was vital. I mean, who knows? I don't know. But that forcing, again, whether you're doing VSED or not, it's really hard on a dying patient to be fed more than they want, to drink more than they want, because their body is shutting down. And it's very, very uncomfortable. Yeah. Use your energy to digest. So, I mean, there's, in some ways, if you're naturally dying, you're going to be naturally doing VSED without even calling it that.
People have been dying this way for generations.
Yeah.
Call it VSED. They just knew it was their time. They'd take to their bed, turn their face to the wall. The grandkids would still be playing on the floor. Nobody was urging them to keep their strength up by eating the soup that I made you, my own hands. It was like, okay, fine. Whatever you want, whatever you need, we're here.
Yeah.
And it was natural. It's the way people always have died. So we've medicalized dying, as you know, and taking it from the home and putting it behind curtains in hospitals. And you know, hospitals get very anxious about this. You have asked me in the past whether VSED is, quote, legal. And it needs to be very clearly said that if you're decisionally capable, you get to decide what gets put into your body by yourself or by anybody else. You don't have to be terminally ill. You don't even have to be chronically ill. If you're a very healthy person who all of a sudden decides that you're going to stop eating and drinking in order to hasten your death, somebody's going to want to do a psych eval, and that's appropriate. right? That's absolutely appropriate because we want to be sure that you're decisionally capable and making a well-informed and thoughtful choice. But the point is, you don't have to be terminally ill. I have many patients who call me up and say, you know what, I'm done. I'm, 85 years old, or I'm 73, or it doesn't even matter. But I've done everything I've wanted to do. All of my close friends are dead. I can't do the things that I can't garden anymore. I can't do this. I can't do that. People have to shop for me. I'm done. What can I do? What can we? So for those people, particularly if they have family that will come and be with them and a physician who understands, any geriatrician who's been caring for many elderly people are very familiar with this. Palliative care is very familiar with it. Basic internist, family practice doc, God help us all, neurologists, not so much.
Yeah.
Sometimes you have to kind of shop around to get a physician who will hear you and respect the choices that you're making. Because nobody's asking them to do anything illegal. It is perfectly legal in all states across the country. I'm surprised that it's not in Australia.
No, it is. It is.
Oh, okay, good.
I
Right.
mean, they have a law that I actually made a point of printing it out, that what is legal now in Australia, both suicide and attempted suicide, that's legal. Refusing unwanted, painful, and futile medical treatment leading to death from illness. So you can
Wait a second.
refuse any kind of treatment.
Yeah, I mean, you just stop right there, refusing any treatment.
Yeah.
You can refuse any treatment. It doesn't have to be futile. It doesn't have to be anything. You can refuse any treatment for whatever reason you want.
And specifically, it says refusing food and drink leading to death from starvation and dehydration. It says that very specifically.
That's pretty out there. That's terrific. I mean,
Yeah.
it's not a legal issue in this country, but there are many clinicians who are unfamiliar with it. And many physicians, or not physicians, clinicians, and by that I mean nurses and social workers and aides and what have you, believe that food and fluid is not medical care. They're fine with you stopping dialysis, or they're fine with you saying, I want off of this ventilator. But food and fluid, that's not a medical treatment. That's ordinary care. We have to do this.
No, but even hydrating through an IV, that is something that you can refuse.
Oh, absolutely. But that's a medical treatment. The point that I'm making is that absolutely food and fluid is an intervention that prolongs life. You get to decide what gets put in your body, and nobody can make you eat or drink if you don't want to. And you have absolute dominion over your body.
You just have to have the capacity.
Yes. And so with that, let's talk about, well, so what happens if you have been diagnosed with dementia? You have capacity when you're told this horrible, scary, awful news. And maybe you've seen somebody die awfully in a nursing home with glop being shoved down their throat long after they wanted it or knew what was being done. But that reflex to open the mouth when a spoon is brought to the corner like a baby bird, the mouth opens and the glop gets dropped into it and then it gets swallowed. Eventually, they'll forget how to swallow, but that might be years from now. And some poor patient aide will be standing there for hours spooning glop into that mouth 3 times a day, unless you have completed a very specific written advance directive and you have a healthcare agent who will implement the directive instructions. So 2 things, you need to write down that you do not want to be hand-fed by anybody. Once you lose decision-making capacity and are unable to feed yourself, you don't want anybody else doing it. And your healthcare agent knows your wishes, and your healthcare agent will implement your choices. And I recommend that everybody do this on a little video, their phone thing. So that the aides who will be taking care of you and can't understand why we're not feeding you will be able to listen to this because they didn't have a chance to know you when you were a full professor at university teaching, many, many classes. They just know you as this body in the bed that they're supposed to feed glop to. So to have a video that says, I made this choice to not be fed for the following reasons. Here's who I am. I'm making a very considered and thoughtful decision that I want you to respect. So.
Yeah. The advanced directive that you've specifically created with other practitioners of wearing different hats was excellent. I loved reading it. I love seeing that there were two options that you could say no food or drink, period, or on request to have that.
Not even request, but just offer me comfort feeding, because by the time you've got terminal dementia, you're not requesting anything, but you might be interested in, you might be willing to, you might eagerly look at and smack your lips. There's lots of nonverbal communication that goes on, right? Mm-hmm. And family members don't want to even imagine that their loved one is hungry or thirsty. So to offer something, you're not going to be offering an 8-ounce glass with ice and a big fat straw, but you're giving little sips. And if they seem to be interested, you'll offer them little bits now and then. You'll also be sure that they're getting palliative care. And if you're trying to not feed anybody anything, you better be damn sure you're giving really aggressive symptom management.
Yeah. What is out of hospital do not resuscitate order? I know about MOLST, I know about POLST, medical order for life-sustaining treatment. Yeah. But I never heard of out of hospital do not resuscitate order. Well, is that a DNR? I don't know that term.
Yeah, in each state has their own laws about legislation around advanced directives and end of life decision making, and so I can't speak for the whole of the country, but increasingly, the MOLST or the POLST, whatever it is. Again, it started on the West Coast and it's certainly come to the East. A MOLST or a POLST in this country includes an option to not be resuscitated. So if you completed a MOLST, you will have indicated whether you want to be resuscitated, whether you want to go to the hospital or not, who your healthcare agent is, and you sit down and you complete this with your physician or your healthcare agent does who knows your wishes. So the out of hospital do not resuscitate order, a DNR order is only good in a hospital.
Okay.
I'm speaking from New York. I don't know what the hell happens in other places. It's terrible. We in New York think center of the world, so we got to be here. And each state has their own rules about this. But so to get around somebody who has a DNR in the hospital and then they're discharged to home, they still want not to be resuscitated. And without that out of hospital do not resuscitate order stuck onto the door, the EMTs will come pounding through the door and they'll jump on your chest and put tubes down your throat unless they see that or unless they see a MOLST. Now, if you're in hospice is going to take care of all of that stuff for you. They're going to be sure that you have a DNR. They're going to be sure that you have a MOLST. They're going to be sure that everybody's on the same page and they've got all of these forms where the clinicians, where the EMTs know what to look. And they also help the family members who panic and call 911, right? And when you panic and call 911, that's the big burly guys that come slamming through the door. So, and that's their job. They have to resuscitate unless they have some legal form that says you don't have to in this case, in which case they will take you to the hospital for pain medication or because you're acutely short of breath. And you should be in hospital for that, even if you are terminally ill, unless you're in hospice. But anyhow, so I'm getting off on tangents, sorry.
No, I mean, I think these are all scenarios that people need to consider, not only for, how their life is likely to end naturally, whether it's from COPD or whether it's kidney failure or cancer, whatever, that there are symptoms that need to be managed at the end of life. And so if you're short of breath, you have an oxygen machine by your bed, because you have hospice and you have all this medical equipment in home. This, again, what really fascinated me about this directive, because I always think about myself when I'm looking at this and go, oh, I want that, I don't want that. What I loved about this directive is that it was very specific about saying, announcing that you want to die at home. And that's the first time I've seen a document that if, it's really good to have that specifically down there if you have that kind of support to die at home.
Well, here's the thing. I mean, I am a big believer in healthcare agents, right?
Mhm.
Care proxy. And so if you have COPD or emphysema or some cancer, you need to be conversing with your healthcare agent on a regular basis. Yes, it's good to have something written down at some point, but if you've got a healthcare agent, you don't need that written document. They should be listening to that healthcare agent. If there's any question, though, if you're not very zealous about being an advocate, it's nice to have that backup position that says, look, she said right here, she wrote down, this was the date.
Oh,
she said,
I would definitely want that legal
she never
backup.
wanted that. Yeah.
Yeah.
But a well-informed healthcare agent is a much more effective tool to get your wishes honored than a piece of paper. Pieces of paper get lost and they get put in a chart and nobody ever sees them again.
Mhm.
So,
Or they're on a Post-it note and they're stuck in a file. I mean, I've heard so many horror stories.
but the Most has done a good job about that for people that are in the last couple of years of life. I mean, it's on a bright paper that supposedly is easier to find. But it's true. I mean, these are hard conversations to have, but as you see your disease progressing, most people who have one of these kind of chronic life-threatening diseases have some idea what they have ahead of them.
Yeah.
Fully, their physician is having conversations with them about what you might want to think about in terms of decisions down the road. Because you need to think, you can't decide this stuff at the last minute. On the other hand, as your symptoms escalate, what you thought you wanted before becomes irrelevant. It's what you want right now. And so long as you can communicate with somebody, that's what should happen. Doesn't matter what you wrote down before. If you can still talk to that clinician, if you can still talk to your family members, that's what'll happen.
Yeah. Yeah. And again, if you have hospice or palliative care, your symptoms will be managed.
Mm-hmm.
They just will be, and they will anticipate whether you're going to have nausea, whether you're going to have anxiety, whether you're going to need more heavy pain medication. And my experience with hospice, well, I volunteer at a hospice here, but it's excellent, and I guess if there's any issue I have is the equity of it. Not everyone, for geographical reasons or, societal reasons, do not have the kind of access to these choices even.
Yeah. You need somebody there in your home with you.
Mm-hmm.
You have to have somebody who will help you with your medication, because you're not going to be able to do it up until the end by yourself.
Right.
You just can't remember when you last took those pills or this whatever, and where is it, and you can't find it and you can't read it anymore.
So I'm curious because, you've worked specifically with patients, but what all end of lives using voluntary stopping eating and drinking, give us examples of, without getting into HIPAA things, but of a situation where it went well and maybe another situation where it didn't go so well, and why.
Well, I kind of thought you might want to know about that, and I can certainly tell you about many of the patients that I've worked with. And let me just say that in terms of when it hasn't gone well, I haven't had that experience because of all of the upstream teaching and talking about and discussing and considering. I think the problems occur when somebody doesn't know what to expect, or I've had people tell me that, oh yes, I'm just going to stop eating and drinking and I'll be dead in 3 days. So we have a lot of work to do, when I hear that. And there's a lot of misinformation around, a lot of misinformation. So if somebody doesn't want to hear what actually is involved in this process, then it probably is not going to go well for them. And the other thing I would say, Claire, is, you know, I've worked with some pretty privileged people, and this is something that nobody else can do for them. They have to do it themselves. And they have to do every day decide whether they will persist in refusing oral intake or not. Are they really going to be able to endure or not? And I mean, the only thing they can hope that they can get somebody to do is perhaps make them really, really sleepy all the time. And that's a conversation they ought to be able to have with their clinicians, their physician.
Which is palliative sedation and is another option.
Well, yeah, but I will tell you, palliative sedation is not universally available. It has to be provided in a hospital. It can't be provided at home. It requires IV medication. And many hospices don't do IVs. You have to have a separate kind of team. And frankly, I've never known anybody who's been able to use, because you just don't use more morphine. That's not how you do palliative sedation. You use medications that cause sedation, like in anesthesia. And that requires special techniques, and it usually requires a hospital stay. And many people don't want to have to put up with that, right? They don't want to have to be in the hospital. So it's a bit of a trade-off. The only time that palliative sedation is appropriate that I've seen it used is when the symptoms are simply intractable. They cannot be managed in any way that's a typical palliative intervention, drugs, whatever. And they're so awful, whether it's constant nausea or whether it's horrible wounds or it's just intractable pain, you have to put that person to sleep. But that's not very often, Claire. And it's not a routine practice by hospices, at least not in New York City. I mean, I can only speak from my experience.
No, I have seen it done at home, but you don't really know whether it's from, I mean, if you're using palliative meds for pain control, that's not going to kill you. But palliative,
and it may not make you unconscious either.
And it may not make you unconscious, but a lot of people, because if you're naturally dying, you're going to go into a coma stage naturally.
Yes.
You know, you may get a higher dose of whatever at home. And for all, it looks like palliative sedation, but it is or isn't. You just don't really know.
Yeah. I mean, I think aggressive use of pain medication is certainly warranted when somebody's actively dying and when would like to have this process over with. You asked me about positive cases and negative cases, and I went to, I don't know any negative cases. So I would say there are several categories of positive experiences with VSED. In one group are elderly folks who have maybe a bunch of chronic comorbidities, but nothing that's terminal. And they have just reached the conclusion that they're done, they're finished. And they want, and many people know about VSED, many old people know about VSED. They know somebody who's done that or somebody's grandmother died that way. I had one couple, I mean, the husband had some kind of miserable cancer. He was at home, he was on hospice. And they contacted me and we talked about VSED, and that's what he did. And it was perfect. It was a wonderful experience for both of them. Although there was one little glitch where she had to call me at 2:00 in the morning because he was being delirious and agitated. And I said, okay, see that little drug that says Haldol? Give him that and call a hospice. But, and then, you know, like 5-10 years later, she called me and she said, okay, now I'm ready. You know, now it's my time. I'm ready for this. She knew exactly what was involved. She had the same doctors who had been available for her husband. She got her kids to come west. It was at the beginning of COVID. And that was before, you know, vaccines or anything. And boy, I'll tell you, this couple, this son and daughter, were so freaked out. I mean, they ate in their car. I think they peed in jugs. You know, they were terrified of having any contact with anybody. But they came to be with their mom, and she hadn't seen them in a long time. And she really enjoyed the visit. And she kept, you know, finding more things to show them and more paperwork that she wanted them to see. And they're calling me saying, what the hell here? You know, we've got to get back to our home. And I said, you know, this is a big decision. She gets to decide when it's time.
Yeah.
And she did. You know, took longer than the kids had wanted, but it was fine. It was fine. And my practice is to call every day and just have a quick check-in. How's everything going? Any problems? Talk to the patient as long as I can. And then when they can't come to the phone or they're too weak, I talk to the kids. And that was delightful. You know, it was 10 days and she was fine. So that's one category of patients. The other ones are folks who have an end stage, really miserable disease like Parkinson's, right? And the thing with those kinds of diseases is, you know, there's some pain, there's some this, there's a lot of different symptoms that have to be kind of managed, and you have to deal with neurologists, which is not my favorite, but when you stop taking medications for that disease, the symptoms escalate. So it's a really kind of tricky process. And I mean, I remember one woman who, she and her husband had this wonderful marriage. She had been a social worker, psychiatric social worker for years, and she was really good at what she did. She found it really hard to leave her husband, to die before he did. And again, you have to just journey along with them, and without judgment, without question, you're just there and you try to help them in any way that you can. So that's sort of a second category. And that woman, she knew it was her only option. She knew it was the only way she could control her own dying. But she was so ambivalent about dying, you know, about being dead and leaving her husband, that it took a long time before she was finally able to sort of say, okay, now I'm ready. This sucks. I can't do this any longer. And then, you know, I used to get calls from patients in hospice who, they weren't in pain because their pain was managed, but their dying was just going on too long. It was just taking too freaking long. And so, you know, back in the day, there were some hospice nurses or social workers that would talk about VSED, but not all of them. And so if they would say, you know, call this organization, maybe you can talk to them, you know, that sort of thing. I think that hospice nurses are more open to it now. I certainly, it's in the lectures and the work that I do, I strongly encourage nurses and social workers. I mean, obviously you explore why are you making this request now? What's going on? Are there symptoms that we can alleviate? Are you worried about anything? Is it pain? Is it this? Is it that? And why now? You know, what's changed between last week and today, and once all of that's done, if they just say, look, I don't want to have to continue. I don't want to have to endure this weight. So, all right, let's see what we can do here. And stopping all oral intake is definitely one of the things to do.
And people that are, first of all, if this is bringing up any kind of issues for people, just that we're talking about dying, you know, and you're having any kind of thoughts of suicide, please contact your helplines, because that's not what we're talking about here. So this may bring up those feelings or thoughts for you. And I just want to encourage you to call your suicide hotlines if that's the case, what we're talking about. But okay, going back to VSED, I wanted to, there are YouTube videos that you can look at and see actually people going through this process and see the kind of support they need and the families that are around them. And and there's actually a euphoria that can go along with this, as I've seen it.
I don't talk about that. I mean,
Why? Why?
well, because I think that if you set people up for, you're going to have this beatific, euphoric experience, you know what? It's hard work to die. It's hard work to die. I don't think it's easy. And there's one video that we have on our website that occurred because this little old lady wanted her daughter to videotape her process of going through VSED. And it's lovely. She's an older woman. She's chronically ill. I'm not sure how she quite got into hospice, but in any case, she did. She was in hospice. She was getting good symptom relief. She didn't have any pain to speak of. And she chatted each day with her daughter about what it was like and what she was feeling. And I think it's a helpful example, but I always caution people to say each person's experience is unique. This is the experience she had. You can't be sure that that's the experience you will have. But people do, you're right, Claire. People want to know what it was like for somebody else. They want to be able to ask questions. But I tell people what's involved. They really need to understand what's involved and what the process is like, and what do you want your loved ones to do when you forget that and you're thirsty? How do you want them to respond? And you have to have a plan for that. It has to be discussed. That's not, you need to know that that's an issue before you can talk about it, right? So I think that anybody that's considering VSED has to be very, very, very well informed. They need to have some experienced clinician talk to them about what those 2 weeks would be like, maybe even longer if you're feeling the need to have, bits to drink than you thought you would.
Yeah. Well, gosh, we could talk about this for a long time. I want people to also hear about your book and about the end of life choices of New York. So if you could just talk a little bit about, if people wanted to get in touch with you and get more information, how would they do that? And just anything you want to talk about.
Well, the first thing I should tell people is the website for End of Life Choices New York. Because if you go to the website, you can find me, you can get counseling, and it's free. We're not for profit. We don't charge for anything. You can see there's a lot of information about VSED and different things that we do. So if you've got a pencil and paper, I'm going to give you the website now. It's www.endoflifechoicesny, all one word. endoflifechoicesny.org.
We'll have the link down below for them to just click on.
Okay, good. And for me, I think if you do, if you Google me, my name comes up and how you get a hold of me and my web and VSED and all the rest of it. But I think that it's Judy at End of Life Choices New York, I think, .org. And there's phone numbers on the website, but there's no point in giving you those phone numbers. I don't even know what the hell they are anymore.
Well, tell us about the book.
Well, the book is an interesting thing. The three guys and I have known each other for years. We met at a conference quite a few years ago, and we started working together, and we really recognized that there was a huge vacuum in the literature. So I can hold this book up. Look.
Do. Oh, I love that. That's beautiful.
Isn't that nice?
Yeah, nice cover. Love it.
So it's called Voluntarily Stopping Eating and Drinking, a compassionate, widely available option for hastening death. It's published by Oxford University Press. It's available on Amazon. It's edited by Timothy Quill, who's a physician, Paul Menzel, who's a philosopher, Thad Pope, who's a big deal legal law professor, and me. And so 2/3 of it is about VSED. So it's like the capacitated, well-informed, contemporaneous decision deciding that you will stop all oral intake. And then the other third is about advanced directives to stop eating and drinking. So we cover both of those topics. I will tell you that advanced directives to stop eating and drinking are becoming increasingly common. Each state gets to decide whether they are going to recognize them. New York hasn't yet, it hasn't actually gone before a judge. I think, of course, it's perfectly straightforward. It's like any other advanced directive, but that's me, right? So presumably it'll go before a judge at some point.
But even if you're not from New York, if you go to the website, you can actually click and print that and take it to your attorney,
Oh yeah, there is something on our website. It's called it's an unfortunate name, Dementia Directive.
Mhm.
And what it is, it's a whole page of instructions that I wrote, before you even get to the part where you're going to maybe decide, here's what you need to think about. Here are all of these things to consider. And then, as Claire said, there are two options. I don't want it, and the clinical trigger is when capacity is lost and the ability to self-feed is lost. And the healthcare agent, together with the primary care physician, agree that now is the time that these instructions should be operationalized. And there are two options. One is the stop everything but give me aggressive symptom management, palliative care. And the other is comfort feeding only. The goal being to hasten death maybe a little bit longer, but I want to be comfortable. I don't want to be thirsty or hungry.
Mhm.
And much easier option for families to support.
Yeah. Well, I've learned a lot from this hour together.
9 o'clock already.
I know, but I mean, that's how dying your way. We really want people to die their way, and we really aren't advocating. Yes, you have to hasten death, or we don't want to see people prolonging death unnecessarily. But it's your choice. It is always your choice. And just having this conversation while you're have capacity and curious, you're going to have such a better outcome,
And just even to have the information and think about it, knowing that you have a choice. You don't have to make that choice now, but know that there's an option out there. If things get hairy for you or things become unacceptable, then you know that you have that option, that's perfectly legal. Nobody's going to get in trouble. It's not considered suicide. God help us all. So it's good to know that it exists. Mm-hmm. Even if you never use it, people are comforted by knowing they have a choice.
Exactly. And most of the people that do the medical aid in dying and get the prescriptions, most of them don't ever use the prescriptions.
Well, I don't
know. But it's
just
an option.
Yeah, exactly.
It's an option. Well, thank you, Judith. Thank you. It's lovely to meet you. And
it's been a pleasure.
I will refer people to your organization because I truly was not aware that New York did not have a legal option to.
Oh yes, we have a bunch of dinosaurs in Albany.
Well,
Tara,
everybody's got to vote, right?
You bet.
Okay.
All right, dear.
We will talk again soon.
See you sometime, will you?
Hey, next time I'm in New York, I'll give you.
Thank you for joining us on Dying Your Way. If it's inspired you, then please spread the word. Leave a rating and review so others can find out about us. To learn more, connect with us on Facebook or our website at dyingyourway.com. A special thank you for the artist Mel Dobra for letting us use her song, Smoke and Flame, as the soundtrack of our show. I invite you to return, hear each episode, and be part of the conversation on death literacy. I am Claire O'Berry, and this is Dying Your Way.